I am Alonso Montoya. I am a neuropsychiatrist. Um, I work as a strategic healthcare partner at Roche, Canada. I have a special interest in digital innovation. And as part of my job, I work collectively through the healthcare industry in order to be a positive and efficient change agent within the Canadian healthcare ecosystem. Thanks for joining in this important discussion about how this pandemic has accelerated the development and the use of digital biomarkers in neuroscience. But first, let me just start this session expressing our gratitude and our appreciation to all our healthcare professionals, our colleagues that have been fighting against this pandemic. We recognize that you are put in high risk to help us, so thank you very much. Now, I would like to introduce one of the panelists and moderators for this webinar, Dr. Tom Mickelson. He is the president and scientific director of the Ontario Brain Institute, a publicly funded nonprofit research center, which aims to establish Ontario as a world leader in brain research, care, and commercialization. Tom has a very impressive career in neurobiology. He is the lead of the brain tumor program at the Henry Ford Hospital. And he was a key person to not only to build the clinical trial expertise in that center, but also to build the laboratory in tumor biology over there. On his work at the OBI, he advocates to have an approach, a very collaborative approach to science in which patient and industry can be engaged in the process. Thanks, Tom, for joining us.
Appreciate it, Alonso. Thank you very much. And thanks to all the attendees, most of whom are kind of friends and family as part of our deployed translational research network. I know a lot of our academic partners are online today. This session really epitomizes what we want to do, is the harmonization of science, the real world, and the commercialization opportunities. And this will be abundantly clear, so I won't take up any more time and get Charles to kick it off. Thank you, Alonso.
Okay, thank you, Tom. Just a few words before we introduce our panelists. COVID-19 has profoundly changed our lives, and particularly the health systems. I think this pandemic has just elevated all the challenges that all the health systems face for a long time, particularly our Canadian health system. Things like the number of health professionals are not enough. We have a huge geography in this country. The burden of chronic conditions like neurodegenerative disorders or neuropsychiatric conditions, the aging of the population. For the first time, this country has more teenagers and young adults than senior. And in a very, very short period of time, the world has been forced to have a digital transformation in healthcare. In a very, very short period of time, we also realized the need to better understand some of the neurological disorders. And probably this pandemic is just helping us to advance in that, to really trigger the true digital transformation in healthcare. With that, let me introduce our panelist, Dr. Charles Alesi. He's joining us from England, and he's a global recognized leader in healthcare. He is particularly expert in health systems and the interface between healthcare, social care, and personalization of wellness. He's a physician working in the UK for more than 40 years. He's also the Global Chief Clinical Officer of HIMSS, the Healthcare Information and Management Society. And with this role, he travels around the world, assisting governments, large chains of hospitals, corporations, in the utilization of information and data, and how this can help to get better outcomes for patients. He's a senior advisor of the Public Health England. He has published widely, and he holds different appointments, academic appointments around the world, in Europe, in the Americas. Here in Canada, he is a research professor in clinical neurosciences at the University of Western Ontario, and he also holds a visitor scholar at the Odette School of Business in Windsor, Ontario. So it's my pleasure to introduce you, Charles.
Thank you, Alonso, and thank you, Tom. I'm delighted to be here. I've been looking forward to today because in many respects, it brings together a lot of the work that we all have been doing over the last few years. And so really, this is setting some context, I think, because I really think it's helpful for us to get an appreciation of where we got to and where we started. And I'm going to take you back to really the late 1990s and really the middle 1990s, where we started to really implement evidence-based care. And before then, we have to remember it was a question of doing whatever we thought was best for each patient, one person at a time, often not remembering what we did with the previous person. And that information and that data wasn't being collected, but evidence-based care allowed us to really compare treatments in a way which was scientifically based, reproducible, and enabled us to be able to develop the insights we needed to improve the care for people. But I think there's been a real transformation from the late 20th century to where we are now, which is 20 years later. That is partly associated with the consumer revolution, of course, and we need to remember the triad of convenience, access, and price around a change in the relationship between organizations that deliver and organizations that accept care or commerce or whatever. And also the effect of the internet, because the democratization of information has really changed an awful lot. And onto this, we now add SARS. And SARS has had an incredible effect upon health and care, where we have seen not an acceleration, but an explosion in the uptake of modalities of care, which move away from the bricks and mortar office visit, which certainly people of my generation have been used to, whereby the only transaction really used to be somebody coming to see me face to face and enabling a conversation, an interaction to take place specifically around the management of non-communicable disease in general. And of course, with neurosciences really in the front of mind here. But all this has taken place in a remarkably fast pace, especially, of course, the last few weeks have really accelerated the change to digital transformation. In many respects, we've made more advances in terms of using new modalities over the last 12 weeks than we've made over the last 20 years. I know that really hurts me to say that, but in many respects, it really has become mainstream. Next slide, please. Which really takes us to a place where we have to start thinking a little bit differently. We already know that the new way of working is evidence-based care for one. You know, the precision medicine type approach is one which has really now started to be not only identified, but implemented globally in terms of the way we manage disease. But perhaps we haven't yet quite appreciated what's happening in terms of the management of lifelong risk reduction. As we know, in non-communicable diseases, there are a series of actions we can all take to manage our risks associated with disease, to enable us potentially to have a much more productive old age. And productive healthy aging is the sort of direction we're going in. And this, of course, not only means increases in longevity, but also increases of, and that's why productivity, the ability of an individual to actually express themselves in any way they wish to. Partly economic, yes, but partly also in terms of being able to enjoy their retirement to their fullest extent. And I think this is something which we're understanding far more. And this is an enormous opportunity for us. So we really are in the age of precision. Could I have the next slide, please? And if we think in terms of what makes up precision health, we're left with a feeling that, you know, this is all within grasp at the moment, and we are starting to see evidence of it being implemented on a global basis. So we know how important it is to activate people. I talk about activating people. It's not a term I particularly like. It's got military connotations within it. But in essence, what it means is ensuring that people have a willingness and ability to take independent actions to manage their own health and care. We know how difficult it is to ensure that people remain engaged in this lifelong journey around risk reduction, the importance of managing diet, the importance of physical activity, the importance of reducing risks like smoking. And I don't need to talk to you about this. You are the experts at the end of the day. But we know how easy it is to access health and care records in most countries. And the answer is not much. But there are some examples globally whereby they have achieved some really quite remarkable transformations, specifically by allowing people access to their health and care records, encouraging them to get activated, and then moving into places like gamification. And this where it gets really interesting. So I use as an example Mycanta because it, I think, is the most obvious and really the most interesting use case example of the effect of allowing people access to their information. So what is Mycanta? Mycanta is the system which exists in Finland for people accessing health and care data. It consists of Mycanta pages, which basically is EMRs, Mycanta prescriptions, Mycanta data, Mycanta social welfare, and it also has a bit around certification. So in essence, in Finland, a person can access their health and care record as part of their normal activity. The only way they can access prescriptions is through Mycanta. And you're talking about a country which may not be typical. It's only 5 million people in terms of population. And certainly it's a very homogeneous society and one where levels of trust between government and population is exceptionally high. I wish that was true in a whole host of other jurisdictions. And I'm not going to go there because I know it isn't. But the journey to get to a state where Mycanta is now the second most accessed healthcare address in Finland has taken them 10 years. They started on this journey in 2010, and it's now 2020. You know, it's taken 10 years for people to get accustomed to and really engaged in their own health and care. And then, of course, for them to be able to access that data and add to that data with their own data around wearables, data exactly around digital biomarkers, which is all added into this record, which is available to the individual, and the individual allows medical and care professionals to access that data as they think appropriate. And clearly they are trying, as other countries are trying, to start to get people to take far more engagement within their own health and care. And there are some examples here using nudge techniques. And that's why I mentioned gamification. And I'll choose an example from Japan, which is particularly interesting. In one of the prefectures in Tokyo, they use a system called Mimosis. Mimosis is a system which you can access through your cell phone. Every citizen can access this app. And using this app, they're encouraged to speak a series of commands into their mobile phone, which is then processed through a central server using AI approaches to try to identify people who potentially are at risk of cognitive decline or potentially are at risk of depression. And they're using these systems together with a lot of others within a prefecture for a whole population to try to get the population to manage their health and care better. And the result of them doing that is a reduction in the compulsory social care insurance each citizen has to buy. So there is a real benefit to people doing this. And the effect this has had upon populations getting more engaged, getting more involved in health and care has been phenomenal. And also, of course, as you would expect, the effect on outcomes has also been phenomenal. Because, you know, this is a lifelong journey. This isn't simply about fixing the fact that you've had a stroke with using the most innovative treatment of the day. This is about not getting the stroke in the first place. And how on earth are we going to value and how on earth are we going to measure our progress unless we start using biomarkers to do that? And of course, we need to remember, yes, we can use epigenetic markers. Of course we can. We can use molecular markers. Of course we can. But there are also digital markers, and we can really use those effectively. Can I have the next slide, please? And then, of course, once we have this data, we can start to really extract the optimal value here, because for the individual, of course, you get an engaged population, you get somebody who's really engaged personally in their health and care. It's really evidence-based care for me, with the aim to actually get to a productive, healthy age. And that's exactly what you see happening in various jurisdictions. For research, of course, you have the ability to mine this enormous amount of data. And really now, with the advent of 5G and the Internet of Things, the potential to develop new digital markers and to use that data using deep learning is enormous. Of course, there are issues around the secondary use of data, which we all understand, but there are also examples and exemplars of places and countries which have actually managed this very well. In Europe, of course, we have GDPR, which is the process which we use around personal privacy. But there are, again, sadly, it's Finland again, we're going to use as an example. FinData is the agency which was set up there to manage secondary use. And it's really the model which the European Union is using to try to disseminate this. We know how important it is for the provision of care to develop insights into care, new treatments on a personalized basis. Again, of course, using AI. And for society, of course, there are benefits. Clearly, having the most efficient use of resources, especially as they're so scarce now in terms of healthcare, is an enormous advantage we have. Could I go to the next slide, please? So really, let's take this into a Canadian context, because we are in a really good place in Canada, I think, because the baseline we have is I think, one of the best in the world. The infrastructure we have here is fantastic. Not only the level of scientific infrastructure we have, which really is special, but also the workforce in general is really exceptional. If you look, I mean, what I do on my global, with my global road, one of the first places I look to when I'm looking for evidence is Canada, because I usually find what I need there. You know, you produce some of the best reviewed, best researched papers I've seen anywhere. And having the skilled workforce, having the potential to activate a population, you know, we are in a good place. And then, of course, there is the requirement because, of course, we have the aging population. We've already talked about this. And in case we forget, of course, we have the aging workforce. Unless we have developed cryogenic chambers to put the workforce in, the workforce is aging at the same rate as the population. So we really need to really start to engage in the use of digital biomarkers. And finally, we have the God-given opportunity of COVID. And I'm sorry to use that term, but I think it's apposite because we have seen an incredible transformation. In the United Kingdom, we have seen a move to modalities other than bricks and mortar, where 85% of primary care consultations are now digital and other modalities. And the same is true in other countries. This morning, it's about 4 in the afternoon here in the United Kingdom. I was having conversations with South Korea. They've seen that transformation in exactly the same way in terms of getting their primary care and also outpatient activities done digitally. And of course, the potential advantage of that is the data governance that you can introduce in those situations, as well as the alignment in terms of guidelines. So we're in a very good place. And really the question is, let's take full advantage of this to ensure we get the outcomes we need, which at the end of the day is the use of all the biomarkers we have, including the digital biomarkers, to ensure we get as healthy and productive a life as we all can. Thank you.
Thank you very much, Charles. Great presentation. And I'm gonna pass to Tom to lead the discussion of this panel.
Yeah, thank you very much. So Charles, thank you. What a superb presentation. I think the perspective you bring is probably unparalleled, and one could go so many directions, and we need more than a couple of hours to discuss some of these critical issues. But it really does come down to data, doesn't it? I mean, I wonder if you'd speak a little bit to the contrast between who has done it well and recognizing the unique values of Finland and some of the Scandinavian countries, which are highly uniform and very engaged, to the perhaps less well-organized either Canadian or UK systems, specifically with regard to the fragmentation of, first of all, data platforms. What about data standardization? Because at the end of the day, you can't AI your way out of a problem where you don't have source data. And this is something we've been talking about in the Canadian context about what about care pathways, standardization, laying a data infrastructure on routine care in the context of pragmatic clinical trials. And if you can actually execute at the population level, then the insights can be gauged, both not just as research outcomes, but in a pragmatic sense for meaningful outcomes in the context of how care is delivered daily. So a couple of comments, if you wouldn't mind, on those issues, because I think we do have opportunities.
I think that's really interesting and a really, really insightful question, Tom, because you'd be surprised as how fragmented some of the Scandinavian systems are. What an extraordinary statement, but you would be surprised. You know, if you go to Denmark, Denmark has been really successful at getting social care interacting with hospital care, and they really have done that well, really, really well. But they didn't include primary care because it was too difficult. And they're really having problems now trying to ingest that, because of course, in non-communicable disease, you don't need that episodic data, you need all of it. So you know, that's one example. In Norway, they have a multitude of systems, a multitude of pilots, a multitude of initiatives. And interoperability is not certainly the first thing that comes to mind in those situations. And in Sweden, you then have a situation where you have some centers of unbelievable excellence, surrounded by, there's all sorts of fiefdoms in terms of data and data management. So the complexities you talk about in terms of the United Kingdom, for example, which is fragmented, yes, but no more or no less fragmented than a lot of these other places. I think the difference is a will to make this work. Because I have seen examples of using data in a way which I wouldn't have believed in some really not necessarily wonderfully technologically advanced countries, because they decided they wanted to do it. I'll give you an example in Europe. In the Netherlands, for example, government decided that, you know, people were interpreting GDPR as the reason why they couldn't do something. Now, we can all use every mechanism we wish to stop something happening. And the government really challenged the scientific the scientific community and also the health community. And, you know, they're really getting moving in terms of getting data together. So that's one example. And this morning I was talking to the South Koreans, and extraordinary stuff. They love technology over there. But they're already using some of the pathways that they developed for sepsis in hospitals, for example. They're tweaking them to start to be able to predict which of the patients are going to develop complications for COVID. Wow. And plan which beds to use. Wow. Yesterday, I was speaking to the Israelis, to Clalit, which is the biggest health and care provider, Ram Balasir, who was the innovation, an old friend of mine. And they're doing amazing things in terms of using data to be able to provide ideal health, which is a process which enables a physician to assist an individual on their life journey around the things which are most important in terms of risk reduction on a personalized basis. So these things can happen. And I think it's too easy for us to say, oh, it's because data's fragmented. Yeah, but it's fragmented everywhere. You know, if we really want to do this, we can. And I think we should.
No, I would absolutely agree. I think it does come down to the big picture about whether it's a good idea versus the nuts and bolts details of how do you actually validate an insight and then plow it down into clinical decision support, which would then be tracked and followed and the outcomes derived. It's really more in the implementation piece, isn't it? I mean, because there's so many evaluations that are done. So, you know, could you, would you, should you? You know, everybody's got a widget, everybody's got a data analysis that is an exploratory, you know, hypothesis generation thing. But how do you actually then validate or verify the insight that then gets plowed down into a care pathway, which is implemented and taken up, and then you track it and yada, yada, yada.
That's the big question, of course. And the real stars here are the people who start doing that, who actually have the ability to iterate their results regularly, are able to actually really sort of change direction as they need to.
Yeah, let me get your reaction to the sort of branded concept around the learning healthcare system. Is this a pejorative, or is this really the crystallizing the idea to government regulators, or what is your personal take on that? Is it an overused phrase, or?
Sadly, I think it's an overused phrase, but an underused concept. That's the sadness. And really, that's the sadness of a lot of our conversations. Because, of course, it has to be a learning health system. How would we treat hypertension if it wasn't a learning health system? I mean, would we always do what we've always done? In which case, what the hell are we doing research for? Is it just to validate what we already know? Surely not. So I think it takes a certain convergence of the need to make things happen fast, and that's why I think this is such an opportunity. The fact that even though a lot of physicians have been worried about digital transformation and also have been worried about the concept of having to change things so rapidly and access of data, and there's all sorts of stuff. The fact that a population really wishes to get the best out of their health and care systems, and suddenly you've got this wonderful triad. And really, it's up to us to lobby appropriately to ensure that we get government to understand the importance of this. We don't get government to stop, for example, issues like reimbursement for digital interactions. And there are some countries which have had real opportunities to do things and stop them, and some others which have really, really raced ahead. So there's nothing like a good crisis to get the catharsis we need to get health and care moving in the way it should. And wow, do we have a good crisis now?
Sure, for sure. So let me just turn the equation a little bit towards the more clinical research side, because obviously we're going to have to put clinical research and what we do in the context of post-COVID. And specifically with regards to, let's say, hardcore regulatory-driven pharma trials, and Alonso might want to weigh in on this, we would like to use biomarker-driven trials for secondary endpoints. But tell me a little bit about what your experience is in the regulatory path towards the validation, approval, and adoption of biomarkers in the context of developing unproven therapeutics. Because you've got two variables, right? You have unproven, untested biomarkers and an unproven therapeutic that you hope to show value. So what is your personal experience with regards to the regulatory side?
Well, at the moment, it's a mess. I think that's where we start from. And it would be unwise, or it would be unfair to say, oh, it's perfect at the moment, because we have a system in Europe using the EMEA, of course, which is the licensing authority for these digital interventions and medtech devices. And we also have processes which are imperfect in other countries using licensing bodies. There's a big mess. And really a less than perfect understanding as to how much importance to be given to these biomarkers as against the biomarkers we understand, which are the molecular ones. I don't think it's fair that we assess these differently, but there is some good news. There is some good news. A close friend of mine has just accepted a job with the English NICE, which is the National Institute of Clinical Excellence, to really head a new team which is looking at how are we, exactly answering the questions you asked, how are we going to actually get that level of understanding in organizations like NICE. It's not a regulatory body, so it's not the complete package, but I think it's an important step to the package, because of course you're going to have to get to MHRA in England, EMEA in Europe, FDA in the US, you know, the normal routes. But I think we need to really heighten the importance of digital biomarkers. We need to start talking about them far more, and we need to start researching their use and researching, I know association, but the more of it we do around this, I think the more important it is. And what an opportunity with 5G and the Internet of Things, where everything has come together already. Countries are getting ready for the second wave of COVID. We know there's going to be a second wave. Well, sorry, we don't know anything. We assume there's going to be a second wave of COVID. And because of this, people are looking actively at the insights we're getting from all our medical records. A lot of that is associated with the use of digital biomarkers.
Right. One of the sort of ironic things is that the data analysis using AI across huge data sets is a hypothesis generating exercise, but it's unfortunately from the regulators a kind of a black box. The question that came up and sort of enlarges upon this, that how do you actually take a population level discovery marker and apply it as in a clinical decision support tool towards a treatment choice for an individual patient? I think those correlations are hard to drill down in the absence of, say, prospective trials.
Absolutely, you're totally correct. We also have a real issue with clinical decision support, I might add. I'm sorry to take it a little bit sideways, but I think it's important. Because clinical decision support, we talk glibly about the fact we have clinical decision support. Clinical decision support, in my experience, is not really built into clinical pathways at all. It often is separate from electronic medical records. It asks too much of an individual that's already pretty stressed with the number of pathways. When I was first a physician, really, we only had a few drugs to play with. And also, I'm not that old, but things have changed really quite dramatically. And also a few pathways to deal with. And the pathways were really generic. Now, oh, whoa, we have a whole load of pathways. And also, we have the addition of COVID onto the path. I mean, it's incredibly complex. And we do not help our physicians by having really intuitive clinical decision support in assisting the physician in the medical record, not a whole series of red flags saying, please check serum rhubarb on Wednesday, which is perhaps important for payment purposes, but not necessarily for the clinician and patient interaction. So we have a lot of work to do. There are some solutions, and that's what frustrates me. But we haven't quite implemented them. And of course, there's lots of vested interest in this globally.
So Alonso, what would you weigh in from your point of view? I'm sorry to dominate the conversation, but please.
Sorry, what happened?
No. I just wanted to bring a question from the audience that I think is quite pertinent. And you already talked a little bit about it, but what about the privacy under these circumstances? We've been observing a massive adoption of telemedicine, and Canada has been using telemedicine for a long time. Ontario particularly is very well known for that. But what about the privacy under these circumstances? I think there is a fundamental right for privacy that still prevails, but this pandemic has probably shown us that many things can be done. Of course, there must be regulation and framework. There's an interest study in other areas, like for instance, in the US, where 85% of the Americans are happy to share data with pharma and institutions just for discovering therapies. 60% of them actually, they are willing to share the data related to COVID, and 20% of them actually are willing to give their data to pharma or academics just for the sake of research. So what do you can tell us about the privacy under these circumstances?
Now, it would be completely illogical if we didn't touch on the balance between the privacy of the individual, and in liberal democracies globally, of course, it's the basis of who we are and the governments we live within, and also our duties as citizens to our fellow citizens in times of pandemic. Now, this is being played out globally in different places, in different ways, with different approaches, from the more, I'm going to use the term authoritarian. I'm not quite sure what it means. From the more authoritarian regimes, which have no difficulty, perhaps, in pushing that balance much more towards the responsibility of the citizen, towards ensuring that all other citizens are protected. And I'm talking, of course, about some initiatives which we've seen in some of the countries associated with track and trace, to others where it's really difficult to share data because people talk more about the importance of privacy. But before we go there, there's a whole issue about telemedicine I think we really need to unpack a little, because telemedicine has obvious advantages, and in Canada, of course, we've been using those advantages because of its sparse population and large landmass. But there are some difficulties associated with the transmission of photography, for example, and images, especially of children, and intimate images, and exactly how those are dealt with, and exactly who has access to those, and exactly what the level of permissions is associated with those. Similarly, of course, with older people and people with cognitive impairment, there are issues around, I'll be simple, the treatment of an older gentleman with balanitis, where perhaps images need to be transmitted. So these are some pretty difficult issues which have to be ironed out. Especially if these gentlemen and ladies happen to be in care homes and don't necessarily have the faculties to be able to give informed consent. There's a whole series of issues. But the discussion around privacy and aggregation of data, I think there are some really interesting approaches. The most interesting, there are two or three really interesting approaches. I'm sorry to talk about Korea again, and it's not only because I talked to them this morning, but because their approach was so different that I think it's worth just highlighting. So in 2015, Korea was hit by MERS. It was hit by MERS badly. Of course, as we know, another coronavirus. It had, I think, 38 deaths, a few hundred people got MERS. And straight after that, they invoked legislation. And the legislation was very, very clear that at the time of a pandemic, and there's a whole series of processes, the state had the ability to access all data of an individual, had ability to access telephone data of an individual, had ability to access credit card data of an individual, to enable the individual to be tracked and traced totally. And that also has a sunset clause, by the way, because, of course, I wouldn't expect people to know the South Korean health system, but the South Korean health system has one of the most stringent privacy rules you could ever see anywhere in the world. So they move from absolutely the importance of privacy to the importance of protection, just like that, like flicking a switch.
Right.
And
on top of that, they actually disclose some of that information to neighbors and things like that, right?
Yes, yes. I mean, there was a scandal because some of the press printed the names of people of different sexual orientation in the recent, so there's all sorts, you know, of course, nothing is perfect, but that approach was really interesting. So I think we really need to start having this discussion with people about the secondary use of data. And I mentioned FinData on the presentation. I spent a day in Finland talking to the people who set it up, specifically the lawyer who actually set up the legislation. It took a long time to get through the parliament, really because, of course, personal freedoms are really important in those jurisdictions. I think we can manage both, but we really need to discuss this openly because the advantages could well outweigh some of the potential horrors that people have. A lot depends on the levels of trust that exist. And in my opinion, there's nothing better to engender trust than to have open, honest conversations, which is, I hope, what we're starting to do today.
Right. One of the questions that also has been come up in the chat, it has to do with the contrast between these large population-based data repositories whereby you can get system-level, outcomes in a broad population versus the individual patient data. So in the Ontario Brain Institute sponsored research network, we have consented patients that are extensively characterized with research-level data, but we also have the opportunity to see them in the context of the larger healthcare system. And I wonder if you are aware of any other jurisdictions in which the contrast is being made between population level resources versus drilling down to the individual and how you actually execute maybe decision rules or whatever for care, or derive insights from care that can be applied then to the broader population.
Well, the last bit of your question, I don't think anyone's done it. In other words, deriving the insights and going the whole way. But in terms of ability to do that, we certainly have that ability within a lot of the socialized medicine systems that exist in Europe. Even the National Health Service has that ability, to get the population health dimension and then move down to the individual. We have, even in Public Health England, we have something called Fingertips, which enables us to look at, and it's available to anybody if you want to Google it, it's just Fingertips PHE. You go into mental health, you find dementia, and you can also start to identify your region and how well your region is managing the diagnosis, the support to the carers, so even on a smaller basis. So we can do that. In terms of implementing the insights associated with it, yeah, well, I live in hope.
Well, I think we are over time now. I just think I would like to thank you, both of you. Thank you, Charles. Thank you, Tom. It has been a great discussion, and we can keep discussing for hours, but unfortunately we have to close this very soon. I would like to thank the Ontario Brain Institute to be a very good partner and to make possible this session today, especially to Krista Studzinski for her support and contributions. And on behalf of the Roche and the OBI, thanks to all of you for attending. We're hoping to bring more opportunities to discuss this topic in the near future. And sorry again for all the technical and the unexpected situations, but I think it was a very fruitful discussion. Thank you again, all of you.